Thank you for joining us this evening. My name is Lawrence Lowe, and I have the honor and privilege of serving you all as the Executive Director and Chief Executive Officer of the CFPC. I'm joining you tonight from Treaty 13 land, where I've been privileged to live most of my life as a settler on the traditional lands of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. Over the next hour, we will be listening and learning. We look forward to answering your questions and hearing your opinions and ideas. Your questions will help drive the conversation for the evening and will be answered in the language that they are asked. Please insert your questions in the question and answer section. Je vous remercie d'être ici ce soir. Nous avons bien hâte de répondre à vos questions et d'entendre vos opinions. Vos questions seront le fil conducteur de la discussion. Nos réponses aux questions seront formulées dans la langue dans laquelle elles ont été posées. Veuillez ajouter vos questions dans la section questions-réponses de la plateforme. I want to thank you for spending some time with us this evening. I know that we all care deeply about the state of our specialty of family medicine, and that we understand that family doctors are the heart of the healthcare system. The current crisis has shown us how family practice is challenging and difficult, but it has also reinforced how indispensable family doctors are to a functioning healthcare system and the health of everybody in Canada. Please know that the college is absolutely dedicated to advancing your interests as members. We continue driving forward in strengthening training, pushing for practice reform, and modernizing the college to serve you better. Together, we will continue to bring our collective voice to advance our specialty and get you, our members, the help that you need. Le collège est déterminé à faire avancer vos intérêts en tant que membres. Nous continuons de travailler pour renforcer la formation, de militer pour une réforme de la pratique et de moderniser le collège. Ensemble, nous continuerons d'unir nos voix pour faire avancer notre spécialité et obtenir l'aide dont nos membres ont besoin. Merci. Thank you, and I'll now pass it over to Dr. Christy Newton.
Thanks, Lawrence. Good afternoon from Vancouver. Bonjour de Vancouver. Je m'appelle Christy Newton et je suis présidente du Collège des médecins de famille du Canada. I'm Christy Newton and I'm the president of the College of Family Physicians of Canada. I live and work in Port Moody, a suburb of Vancouver that lies on the unceded traditional shared territories of the Coast Salish people. It's been my privilege to meet with members from coast to coast, listening to what challenges they face and learning what's important to them. J'ai eu le privilège de rencontrer des membres, d'écouter les défis auxquels ils sont confrontés et d'apprendre ce qui est important pour eux. The town hall today is meant to be an opportunity for you to share your thoughts and ideas, which will help inform the CFPC's new strategic plan. We're here to listen and learn so that we can use our collective voice to help chart the course for the CFPC. This town hall is just one of the several ways we are listening and learning. As you may have seen in a recent member communication last week, there are also opportunities to meet with Lawrence personally in virtual coffee chats. In addition, in March, we began collecting feedback from members online. And so far, we've had more than 500 responses, almost 600, I believe. And I encourage you to add your voice to the conversation by May 2nd. The member exclusive link can be found in an email that was sent on April 18th. It was also included in each issue of Info Digest, and we'll put it in the link in the chat tonight. So thank you to everyone who has responded. I'm going to give a quick snapshot of what members have told us so far. 1, advocate for things that help me as a family physician, such as administrative support, national licensure, locum availability, wellness, and compensation. 2, highlight my important role as a family physician to the public. 3, promote the career of family medicine to medical students. 4, support early career physicians in first 5 years of practice. And 5, provide resources and support for rural family physicians. So those are the top 5 that we've heard so far in that 500 to 600 member responses as we listen and learn. So, encore, je veux remercier d'être ici ce soir. So now let's hear from you.
Yeah, so just looking at our list of questions that we've received so far, I'll just read this question that we've received, Christy. It says, the CFPC does not negotiate on behalf of provincial associations for better master agreements, and really saying, if the CFPC can't do anything for me aside from tracking my main pro credits, why is membership so expensive for an organization that doesn't have the power to affect meaningful change? Can we reduce our fees to correspond better to the lack of services provided? And I think this is actually a really important and valuable question to get started with, because the CFPC, I can hope that many members on the call understand, is so much more than just tracking main pro credits. Really, prior to the creation of the college, and one of the first things I was brought into in my new role in leadership with the college was to really understand the inception and genesis of the CFPC, why the CFPC came to be nearly 70 years ago in the 50s. And one of the clearest things that I can say as a civil servant, a former civil servant, now serving in this role, is that to effectively advocate to government, you need to be able to have a clear definition of what you're advocating for and what is it that you're asking, and on what standard or what basis you are moving forward for. So the CFC continues to have at its core the importance around standard setting through the certification exams, through accrediting residency programs, through ensuring that it's not just about tracking main pro, but making sure that there is quality continuing professional development and materials that are there to support physicians throughout every aspect of their career, and also in ensuring that we are recruiting the best and brightest from undergraduate and postgraduate, through undergraduate and postgraduate training programs to become family doctors. And all of that work really helps to define the specialty of family medicine, and gives us at the College of Family Physicians, as your voices and as your leaders, on behalf of all of us as a collective of the family medicine community, to really speak to what is it that family medicine does? What is it that family medicine needs in order to be the absolute best and to continue being that heart of healthcare that is so essential for our college? So, the work that you're all the work that we do every single day in and day out is to really make sure that those standards are maintained, that new members are being welcomed into the fold through the various certification processes, and that we are really making sure that policymakers and decision makers understand the value of family medicine. Christy, did you want to add to that, perhaps?
Sure. I mean, I think this is a great question, and I agree with you, Lawrence. We are much more than just tracking credits. We actually define the profession of family medicine in Canada, and as you say, we set the standards. We negotiate with the regulatory bodies with respect to saying, these are the standards. A certified family doctor in Canada can do this. And so we sit at those tables to support our members at the licensing bodies and things like that. The other piece is, we have our sphere of influence in defining the curriculum for undergrad family medicine, the postgrad family medicine, CPD, accreditation of institutions with respect to family medicine. So all of those standards pieces. And we sit with our colleagues who have those other sphere of influences. And I'm going to reflect. I've been a BC doc since 2001, actively practicing. And what has been fascinating over those couple of decades is how the more aligned and the more collaborative all of those different groups have become. And as we have become unified, we actually have created synergies and strengthened each other. So I sit, with the doctors of BC and the provincial side, but we also work closely with the CMA. And so I think that united we stand position has really far more influence. And so while that partnership piece, we work in partnership with our colleagues and other organizations, and we recognize our value proposition within our sphere of influence that way.
So, that actually segues nicely, Christy, into our next question, which really speaks to, can you, I think we've answered to some extent, outlining the benefits that the college has for family physicians. We've covered off those, but the other question that this member has for us here is, how can we get more involved in college activities? Sometimes it feels, everything about the college feels inaccessible or far off. And I would start the answer to this question out by really making it very clear that this college is your college. Ultimately, if you're a family doctor practicing in Canada, the CFPC is your collective voice, and it's only as strong as all of us within the tent. So certainly, joining conferences, joining different interest groups, even attending tonight. This really shows that your thoughts are being heard by those of us who are working to advance the specialty of family medicine, and we really encourage you, of course, to contribute in those manners. I can mention as well, prior to my role here, while starting out as a comprehensive family doctor in Brampton, Ontario, many moons ago, I actually subsequently went on through a number of years as a senior, leading up to senior leadership within various medical and public health agencies. But I always maintained my membership in CFPC. I attended FMF. I would contribute to the Canadian Family Physician Journal. I even volunteered for exams, and also volunteered and worked with the Best Refer Center. So there are lots of opportunities if you're willing. Of course, we know everyone's got challenges with the time. But there is definitely, if there's a desire to get involved with the college, we are more than happy to hear you, even if your views, regardless of your views, regardless of your perspectives, we are definitely stronger than some of our parts altogether. Christy, did you want to add to that question about getting involved in the college?
Yeah, exactly. I mean, I was trying to count the number of committees that I bounced from throughout the many decades that I've been involved in the college. I actually came to it quite late, in that I hadn't been involved in the section of medical students or the section of residents, or even the first 5 years, although I did start within the first 5 years on the patient education committee. And worked my way through a variety of them. The other piece is we now have these member interest groups, which I think are also a great way. If you're not ready to step into a committee role or a working group role, just check out the member interest groups to get yourself familiar with part of the college as well. And it may have a practice area that is represented in the member interest group. And then the other piece is, as many of you will know, I also was the president of the college at the chapter in BC, and so was involved in that slowly, starting with one of their conference committees and then working my way into the chapter as well. And so I do think there are opportunities. And then we do have the sort of contact us and provide us feedback in addition to our listening and learning. It's ongoing, and we're always open to hearing from members. And I always say my inbox is always open too. So I hope that that's been helpful. But try it out, because not everything is for everybody. And I do think there are a variety of opportunities that can be adjusted based on the amount of commitment that you're interested in.
Absolutely. Well, in fact, we're now getting into some other questions here, Christy. I'm just noticing we have quite a few questions, so we'll try to keep our answers brief so we can get to as many questions as we can. But so the next question really speaks to, why are we advocating for increased administrative support? And why is the CFPC advocating for increased administrative supports instead of taking practical steps to reduce the administrative burden in the first place? And I think the best way to answer this question is we're actually asking for both. We are asking for admin support because we know that there is always going to be, admin burden in any family practice. But we also have, a clear ask about reducing forms, rationalizing some of the requests for letters or forms or assessments, in general. So we are actually asking for both to a large degree. And Christy, given your work as well, I didn't know if you wanted to add on to the question of asking for admin supports and scribes and all those pieces versus reducing burden. I think the college is actually supportive of both of those things happening to a large degree.
Yeah, both. It's a both and for sure. Yeah.
So, fantastic. So the next question is the CFPC needs to promote itself more to its members. Members need to feel they belong to the CFPC. The CFPC needs to promote family physicians and family medicine residency. Christy, maybe I can give that to you this time to start out.
Sure, I completely agree, and we're doing a lot to try and promote to both undergrad family medicine, so the undergrad programs, and then also in the postgrad programs, and also with the first 5 years, and our other members. So regular meetings across the country, different. With the undergrad deans, with the postgrad deans, with the Association of Faculties of Medicine deans, and then section of medical students, section of residents, then family medicine interest groups. So that's one thing that we meet as president, get to meet throughout the year with all the family medicine interest groups. Then we get to support different programs. Like there's a great program that started in Calgary called Med Zero, which highlights family medicine as a career and some of the aspects of hands-on things that you can do as a family physician. And then trying to dispel some of meeting with the programs and the section of residents and the section of medical students is dispelling some of the myths of family medicine and really addressing some of those ideas that we're a default and that kind of thing. So really championing the fact that there are unique competencies of the specialty of family medicine. For example, if you can't manage uncertainty or an undifferentiated problem, family medicine isn't something for you. If you need to know the answer and have a very detailed algorithmic response, probably not something for you. However, if you can take and synthesize a broad amount of information and bring it down into a prioritized or a selective list of things to do. So we just so I go out and I celebrate some of the positive, unique aspects of family medicine with all of these different groups.
And I would just add, of course, that the CFPC is keenly aware of the value of family physicians. We are the only national organization that is exclusively dedicated to advancing the interests of family doctors in Canada. And it is really important to highlight that at every decision table, in public forum, wherever we've been speaking, one thing that I've been making very clear to policymakers is that investing in family medicine is worth it. Family medicine is worth it. Family medicine is the heart of the healthcare system. And that's a message that myself and the rest of the leadership, Christy as president, and the rest of our board, we will continue to advance, to highlight and promote the unique value of family physicians within the healthcare system in our country. So the next question we have here is, does the CFPC collaborate with the OMA section, or really broadening this from a national perspective, the PTMA sections of family medicine, and is there overlap? I think I'll start just by saying that the CFPC has 10 provincial chapters, which are our representatives, our boots on the ground at the provincial level to a large degree. And there is definitely a lot of interconnection and work between our provincial chapters and national, as well as the provincial and territorial medical associations, and similarly at the national level between the Canadian Medical Association and the College of Family Physicians of Canada, as well as the Royal College and other major national players. So I think the work of the CFPC necessarily is about making sure that we are bringing the family medicine voice to all those tables and with all those partners, together with our 10 chapters at the provincial level. And that actually speaks to another value of your membership, of the work that we do at CFPC, to be able to actually be bringing our leadership and that family medicine voice to those tables, more than just an individual family doc who really, your focus is on your patients and caring for your patients and your community. We're doing that for you, so that you can get the support that you need. But Christy, I didn't know if you wanted to comment on any overlap or connections with PTMA sections of general practice and family medicine.
No, I think you captured it well. I think that really we rely on that local context with our chapters, and we try and support from the national side our chapters to engage in those conversations and ensure those collaborations.
Thank you, Christy. I appreciate that. So the next question, I'll maybe pass it off to you to start. It says, where does the CFPC stand on redesigning healthcare in Canada, where primary care is in crisis? The present system leaves Canadians who need care the most are as the least likely to be able to access such care, almost 5 to 6 million people without a primary care provider. And those that do have one do not get timely access to care, overwhelming emergency departments. So where does the CFPC stand on redesigning healthcare in Canada?
That's a great question. So that is one of the key points of our advocacy with all of our meetings with ministers. So the recent report on transforming the healthcare system indicated that we need more family physicians and healthcare providers to bolster the system and address the crisis. And so, and basically our response and our advocacy has been, great, numbers are going to be helpful. We do need more. The complexity of care and the complexity of the system right now, we're going to need more healthcare providers to address the crisis. But if you bring in more without changing the system, they're going to do something else. They're not going to go into comprehensive longitudinal community-based care where the crisis actually is the most, where they're not going to attach those near 6 million people across the country. So we're championing changing the practice environment, teams. We really need to look at how each province is rolling out team-based care. Different models slightly, but all bringing in the criteria from the patient's medical home vision. And we need to look at compensation reform. So we really need to modernize compensation. We recognize that just over 70% of family docs are still fee-for-service. We need to look at other models, or blended models at least, which will help support the implementation of things like team-based care that will share the load, attach more patients to teams as opposed to building family physician specific panels. So yeah, it's a key area of advocacy for us, and we're providing very specific solutions to the ministry to support family docs in that practice reform.
And I think that really speaks to the overarching to a lot of the challenges that we're facing. Team-based care really represents a solution. Certainly the questions, the collaboration more so than competing with other providers. There's more than enough work to go around. It's about organizing ourselves together in an effective and optimal manner so that we can actually be force multipliers for each other in terms of the care that we're able to provide, in terms of something more than the sum of its parts, but also addressing a lot of the challenges, the lack of coverage, the lack of administrative supports, all those other things. That's also crucial, and to a large extent, rolling out this model far and wide is meant to address a lot of the irritants and pain points that exist in day-to-day practice right now, which actually is a really great segue into the next question that we have here, which is, oh, and I'm sorry, I've just lost the Google Doc. Here we are. It is, the question is, really appreciate all the examples of the things that CFPC is doing for us. Just that I feel I'm getting disheartened, because if CFPC is advocating for us in all these ways, why isn't anything changing? Who or what is standing in our way, or am I expecting too much too soon? I think the first thing that I'll start quickly to just say is, while CFPC is, absolutely there, in your corner and really trying to advocate, the reality is that healthcare and a lot of these decisions ultimately get made at the federal and provincial levels, typically the provincial level as well. But I think there are glimmers of hope, and I know Christy has a really great insight into some of the hopeful things we're seeing around all the different provinces. So I'll let her speak to that. But I think what I really wanted to say is that we are just as we on occasion, when we see the setbacks that we're facing, we're just as disheartened as you. We are just there with you. But I think for us, we basically say, no, we got to redouble our efforts. We've got to make sure that we're putting it forward. Especially even with the recent CARMS match, I think you got to take out and look at some of the positive things that are happening. And one thing that I was very thankful for, even with everything that happened with the unfilled spots in the first iteration, was I said at least there was still 1,361 people who matched into family medicine. They are answering the call. Those are our future family doctors. And so I think you take comfort in what we can change and what we are seeing change. While it is disheartening to hear and see things going, I think the alternative of just like sitting there and not doing anything about it is perhaps a bit more concerning for me, at least. I don't think we're going to be sitting around too much. But I know Christy has also been heartened by a lot of the changes nationally and provincially. So maybe I'll pass it to you, Christy.
Yeah, so I agree. I'm one of these people who you think of a good idea, you've got the evidence to support the solution. It's like, why wasn't it implemented yesterday? So I do think, the fact that the CFPC is at these tables being invited to speak to the Minister of Health, next week, I think it is that we're going to Parliament. And so that we have built these relationships and they're looking to us for actual concrete solutions. And so just some examples that it does seem exceedingly slow. But there are incremental improvements across the country. So PEI has fully embraced the patient's medical home model. They are rolling ahead in collaboration, and we should be able to leverage how that goes in PEI to scale some of those successes that as they implement the model province-wide. The Atlantic region, May 1st, is moving to a regional licensure. Again, things to watch with respect to our advocacy around national licensure and locum availability across the country. And then I believe what's already been commented on in one of the questions was with respect to the success in the BC model with the negotiations for compensation change and equity in the community. These are all things that have taken, to be honest, years to move forwards, but they're starting to move forwards, and they're actually starting to move forwards, it seems, a little bit faster. So while I agree that it feels like it should have been yesterday, I do see, I'm optimistic.
And I would just add to that, Christy, one thing is we do know that the federal funding announcement to support additional family medicine or family practice services that was out there. That's also another outcome, I think, just in respect of starting to see outcomes of advocacy, et cetera. And I wanted to just bring forward another question that's related to the answers we've given here. When I read these, it's like, my colleague, I'm just reading this from the chat. My colleagues and I are burnt out, tired of our work being devalued, exhausted from the constant download of work. How are we advocating to help GPs currently in comprehensive care practice? More funding for additional teams is needed and important, but does nothing to help those currently practicing. Colleagues leaving, contemplating leaving. I will likely not be far behind. I can no longer in good faith recommend family practice to the medical students I teach. When I see stories like this, it gives me further fuel for my fire to say, yeah, we need to really do something about this. We need to be sharing stories like this with every single policymaker out there and just saying, for too long, there has been too much taken for granted in respect of family doctors and family practice. And really, we're fast to the point where a stitch in time saves 9. We now need 9 stitches, and you need to give us those 9 stitches so that we can continue to be the heart of healthcare and really make sure that we're keeping people, everyone in Canada healthy and really keeping things out of the acute care system. So thank you so much for sharing those stories. And really, the more you share those stories with us, the more fodder that gives us to actually advocate and push for changes with our policymakers and with our decision makers. So the next question, Christy, actually speaks to your articles in the April CFP journal, which basically just a comment here saying, really appreciated the 2 articles in the journal, your article on family medicine having become more complex and a discussion about funding. And then also in April's edition, Dr. Kolber's article about the value of family medicine and an impossible job done impossibly well. And I think the question here says, has the new BC funding been more fully reviewed by Ontario? Did you want to talk about just the idea of different provinces and different states and where they are? I know we had that discussion with the constituents just a couple of weeks ago.
Yeah, so I mean, it's a great question, and I think it's early days for anybody to really know whether what the long-term impact of this compensation change is, and to be honest, I reflect on it is it really. I think the ministry's intent with the compensation is to attach more patients, and maybe in the long term, patients will be reattached or attached to docs who have. But what I think initially, what it's going to do is prevent detachment. So I think it's a retention solution, and we're not seeing the retirement rates that we saw before the new compensation model came in. Have other provinces looked at it? Other provinces have actually implemented varying models of things. And I have to say, there's fee for service, antiquated, driving volume, not driving quality, not addressing complexity, resulting in moral distress for those of us who want to provide good care and keep our practices open while we're paying to actually practice. So the vast majority are still that way. What we need is new models that support a salary, that support capitation, that actually maybe are blended in some way to retain some of that opportunity and nimbleness in your earnings, because you may need to buy a new car, you may need to pay off a loan. So salaries are good for paying off your mortgage. Anyway, each province is starting to look at these different models and recognizing that fee for service does not provide the care or motivate anybody to provide the care that is needed by the Canadian population right now, based on complexity and practice costs. I don't know if I've even answered that question.
No, I think there is a lot of transition that's happening in various provincial healthcare systems. And, the question, has the new BC funding model been more fully reviewed by Ontario? I imagine, having worked in government previously, many governments are always looking at other models to understand what works, what doesn't work. And, we imagine that they're all keeping a very close eye on this, given the prominence and importance of family medicine and the primary care crisis that has really, that we're continuing to highlight through our advocacy, that really needs their attention now. The next question says, how soon do you think we can achieve national licensure? And this is an interesting question. I think Christy mentioned it in one of her previous answers, that we do know that the Atlantic provinces are starting to move forward with a reciprocal arrangement amongst the 4 Atlantic provinces starting next month. I think this is obviously something that the CFPC continues to support and has supported for quite some time. We recognize, of course, that there are lots of questions, and we do need to work with our partners who are, are on the medical regulatory side to ensure that all is clear and that the standards are maintained. But I think there is at least a promising start with what's happening in the Atlantic provinces. Christy, I didn't know if you had any additional insight on that one in terms of when we think we can achieve national licensure.
No, I think what it does remind me of is that not a lot of family doctors in the community probably know that there's the Canadian Medical Forum, which pulls together the partner organizations, and that's our opportunity. And national licensure is this opportunity where the CMA, the CFPC, FEMRAC, the AFMC, all of these acronyms, alphabet soup. So anyway, the students, residents, Indigenous Physicians of Canada, Black Physicians of Canada. So there are a variety of organizations at CMF, and these are our tables to discuss these things and move these things forwards. I believe it is something that we'll be watching the Atlantic region, and see how that goes, and hoping that within a year we'll have a better understanding of that and perhaps a national licensure.
Thank you, Christy. So just noting, we've got about 11 more questions and 24 minutes. So I'm going to try to make sure we get through what we can. The next question says, what was the basis for the decision to expand family medicine residency from 2 to 3 years? Another year and a new graduate could elect to do specialty training and expect much higher compensation for their work. Will this not be another barrier to graduates selecting family medicine for their life work? And I think it goes back, my answer to this question, it goes back to what I said in another question, which is family medicine is worth it. And we absolutely want governments to invest in better training to make sure that those who are going into the specialty of family medicine are absolutely well prepared to practice comprehensive practice. The Outcomes of Training project is the project that led to a decision to strengthen residency. But really what happened was the college consulted with members, consulted with practicing physicians and said, in order to practice comprehensively, in 2023, or whatever the case is, whenever this was done between 2018 and 2023. So at some point in the last 5 years, what is it that new graduates need to know, need to understand? That included things like mental health and addictions. It included things like palliative care. It included things like Indigenous health and culturally competent care. And so a whole list of things were added, to which we then turned around and actually went to people who are involved with residency curriculum development and said, if we were to actually create something that ensured that graduates got the best residency education they possibly could, how would this happen? And I think the concern became that just, on the sheer basis of the amount of time that they had available, that they wouldn't be doing these important topics justice in making sure that residents are fully equipped. So I think that's the first thing that I'll share. And the second thing I'll share is that at this time, we're actually in the process of just developing and looking at what the additional and strengthened training is going to look like. It's not necessarily going to be more of the same, more time. It's actually going to be looking at more of a transition to practice year, really to ensure that there's almost like a semi-autonomous period of transition out, and to make sure that our new graduates are actually supported for a longer period of time and not necessarily just going through a whole bunch of other subspecialty rotations. But Christy, I know you've spoken very passionately on this topic as well, and so maybe I'll pass it to you to add on to that.
So there are so many things that I'd like to say. So first of all, in speaking about national licensure, that's one thing. We need to make sure that our resident trained in downtown Toronto is prepared just as well as a resident trained in NOSM, in Fort St. John in BC, in Kelowna in BC. They have the same competencies and are prepared to work anywhere in Canada. Recognizing that when that curriculum was designed, it was the world was a very different beast. And that family medicine has become more complex. The system has become more complex. Things like that, as a family medicine preceptor myself in my practice, I don't do point of care ultrasound. And so I don't know how many preceptors are currently prepared to teach point of care ultrasound, but POCUS is going to be the same as having a stethoscope, right? Having an ultrasound in your hand will be the same as having a stethoscope when our med students now are graduating. And so I think this is something and we just didn't have space in the curriculum. We also want to introduce new curriculum and highlight, how do we lead teams? How do we manage complexity and navigate teams in complexity? How do we introduce quality improvement? How do we integrate data into our practice? There are so many more things in the curriculum, and we want to do it in a wellness and balanced way. A couple more things. Evidence that we've got internationally, first of all, we have the shortest residency training. Evidence we've gotten so far is that every time a program has extended, there hasn't been a drop in applications. It has actually stayed the same or increased. There is a cognitive bias regarding value and length of training that I'd like to let everybody know, that you are a more valuable profession if you have trained for longer. That's just a cognitive bias. We are not doing the same thing. This will be a service-oriented or transition to practice, community-based, longitudinal type experience, and we are engaging program directors to ensure they have influence and make sure they have those contextual pieces. And we're contemplating where the licensure exam is, or not the licensure exam, the certification exam, apologies, is going to go. Is it going to go between second and third year? Still a conversation we were just having today at the Family Medicine Specialty Committee. So there are lots of things. This is just our phase 2. This is our working through what this is going to look like. And our current timeline has a few programs or sites moving to the third year program in 2027, which would mean the first grads of these early adopters would be 2030. So yeah, that's all I'm going to say. We have lots of questions now.
Absolutely. Yeah. And I'm going to start grouping a few of them together. I'm going to just get one out of the way fairly quickly, though, which is a very important question that all of our members should hear the answer to, which says it would be nice to see the expenses of the college, administration, salaries, etc. Can we see the budget somewhere? Thanks for transparency. So we're going to put in the chat, or at least our team, and I'll put it in the chat here, but I'm not sure if that's where it needs to go. But that's a link to our most recent audited financial statements. But I think it's really important for me to add, as with every budget, there is usually an explanation or an interpretation behind it. What you will see in that budget is really the salaries that support numerous staff that are fully dedicated to all of you as members. The staff of the collegeship, the leadership and the staff and the volunteers and the board and everyone that's here at the college, that money is used to advance your interests, whether it's continuing to maintain rigorous standards of certification, rigorous standards of accreditation of residency programs, all of the work that goes into evidence and data that supports advocacy as well as supports your practice, as well as ensures that you have high quality continuing professional development, and also that you have people who are actually able to help you out when you have members what you call with questions about your membership, etc. So those resources absolutely are your collective investment in advancing the specialty of family medicine and making sure that we are able to continue to serve your needs and bring your voice as family doctors to the national stage. Christy, I didn't know if you wanted to answer anything of that question either. Okay.
No, that's great. But I do see a question related to the third year extending training and with respect to highlighting long-term care. And so whoever wrote that question is key. This was one of the areas that we identified as needing bolstering. And so the hope is that we will strengthen the curriculum and provide additional experiences and exposure to most, if not all, of our residents in long-term home care and care of the elderly. I mean, considering the demographics of our population, it would be unfathomable not to strengthen that area of the curriculum. The piece about focused practice, and so another piece that I think we at the college are working with, and we would appreciate input on, is how do we, so in my I'm just gonna reflect on my practice. I have a couple of docs who do intrapartum care. I do maternity care. I no longer actually catch babies. And so I have engaged those docs with a bit of a focused practice to support me. And I think we need to work on those relationships with our sports and exercise medicine docs, our emerge docs, just to model for our residents how you can have a panel of patients and still do emerge shifts and still cover the palliative care group in your community, and still have that interest or focus that addresses some of the needs of your community. We haven't figured it out exactly, but we're working with our member interest groups and with our academic family medicine on how we can really engage with our enhanced skills docs to really support that comprehensive longitudinal practice as well.
So yeah, and I think there's also this other question that we have here in respect of the CFPC's position on family physicians working in long-term care as a whole. We know that long-term care was exposed during the pandemic, and one colleague feeling that the CFPC is feels less and less their professional home and a voice needed with the provincial colleges. I also am tying that to another question I see here around CPSO requiring increasing change in scope of practice requirements for family medicine roles in respect of trans care or occipital nerve blocks without understanding that this is all part of comprehensive family medicine care and limiting ability to provide care for patients. How can we advocate? So I think this really speaks, if anything, Christy, again, to the points that we've been making around the importance of strengthening training, right? And really that helps us build the case to regulators to say that, no, in fact, this is comprehensive care. Comprehensive care is long-term care. Comprehensive care is trans care. Comprehensive care is all these things that we've included in respect to training, even while we continue to make the case for it based on professional development and career trajectories for current physicians at the same time with regulators. I don't know if you wanted to add on to that, the questions around just it seems that there's increasingly a need for us to advocate for things being part of comprehensive care. Did you want to comment on that, Christy?
Yeah, I think my answer with respect to we're still working on that balance, but as we're doing that, part of what we're doing is making sure that we strengthen the curriculum in these areas, so that there are going to be more graduates who are comfortable to continue, and then there'll be some that are going to continue onto a more focused practice. I think there's a balance there that we're going to figure out, but strengthening the overall training in these areas is going to be key to start with.
Absolutely. Go ahead.
It leads a bit to, there's a question in here, sorry, I'm scanning ahead, about pharmacists, nurse practitioners saying they can do the same job as us with less training. Governments also seem focused on funding this instead of comprehensive family medicine. So what is the CFPC doing to advocate for comprehensive family doctors as the foundation? Well, that's exactly the statement I start with when I'm talking with ministers, is we are the foundation and evidence, and we provide the evidence in follow-up or ahead of time in our backgrounder that shows the cost effectiveness of family doctors. And actually, without family doctors, most of these other professions, our allied health professions, are limited, are sometimes struggling to work to top of scope. And so when you have a team that is built with a family doctor there, you can actually support nurse practitioners, family practice nursing, clinical pharmacists to actually work to scope. And so I think there is, with the, and we do have the evidence about cost effectiveness. We also have evidence about the cost ineffectiveness of systems built on other health professions, not family medicine. And so I think it's what we need to do, though, is champion all of it. There is enough. We need to champion family physicians as the support for these teams, and it's when working effectively as teams to scope, we can actually attach more patients, address the complexity of the healthcare system right now.
Yeah, and Christy, if anything, that actually ties somewhat into the other questions around equitable team-based care for patients and family physicians, how we can lobby for this, especially in geographic areas where it's needed and most targeted, and where it's needed the most and targeted funding for complexity. I think you've heard from all of our answers to date very clearly that the CFP is extremely supportive of moving to team-based models, particularly recognizing that this actually allows everyone to practice to top of scope and support the complexity that is a part of really working in communities nowadays. But I also wanted to address this other question, which really speaks to Isn't there a way to bring about teams while maintaining fee for service? And then this question of loss of autonomy with salary and blended models. I think it's really important to highlight, in terms of remuneration models, salaried versus blended are two different things. I think obviously there is a concern in certain models if you are salaried and directly paid and such as accountable. But there are other ways to actually organize blended models as well without necessarily changes in one's autonomy. And I think there are certain examples that we've spoke about with various provinces that may serve as a bit of a blueprint or a roadmap to that part. Christy, did you want to comment on that? And there's also a similar question around just patient autonomy with a patient medical home model and strings.
Oh, wow. So a couple of things. I think it speaks to, there are a couple of things. So looking at teams, and we know from our new grads that over 85% of them are looking for a team-based care environment. And each province, as I've mentioned, is sort of rolling out these team-based care models based on the criteria of the patient's medical home, but in a different way at different rates. And I think it speaks to why they're going slowly, because there is this balance with respect to the professions working within a team and really making sure that we figure it out. And then making sure that patient safety and patient care remains at the heart of all of these decisions that we make. There's some work that the second part of that was there's some work that I was doing with respect to transitioning to a team-based care model and working with patients on what do they think about that? Where do they feel? How do they feel they want to be integrated, connected with? And it's actually what I've learned is there is a spectrum. There's some patients who are wanting to be at the center of a team, and so and there are some that actually want to be part of the team, so patient partnered care. And so it's figuring out these relationships as we go, and making sure, as I say, so somebody who's saying we're not going fast enough, it's like, well, there are some questions that we need to figure out before we jump into a model without adequately making sure we've had consideration of autonomy and the patient's role and all those types of things.
Yeah, so I think we're just getting down to our last questions here. And so there's one question that says, while provincial medical associations are the organization that negotiate physician fees, they represent all physicians. And just someone asking, until we have a body solely negotiating for family physicians, we'll continue to see a huge wage gap. Why can't we have our own negotiating organization in partnership or maybe through the CFPC? I think this is a question that really traditionally the medical associations have been there, and I think that many medical associations are sympathetic to the challenges that family doctors face. But I think ultimately, there is still that cognitive dissonance that Christy spoke to in respect of training that we're fighting up against. And then it really speaks to the continued importance of the work that we do as the CFPC to advocate and really highlight. I mean, simple statistics, for example, that almost 60 to 70% of care in the community is provided by family medicine, but we receive only 10 to 15% of the dollars. I think that really speaks to some of the challenges and highlighting that disparity and really continuing to advocate and working with medical association partners. Is hopefully will continue to yield. Hopefully will yield some fruit. Christy, I didn't know if you wanted to comment on that one, and then we'll move to our last question.
No, I think that's fine. I think we have some more questions and not enough time.
Absolutely. Oh, no. But I think the last three questions are kind of all tied together. So, and I think it's an opportunity for us to speak to just the value and importance of family medicine. So it says, family medicine is expected to be the foundation of the healthcare system, but not respected with financial support. How can we negotiate with similar clout as secondary or tertiary care settings, despite the fact that we're seen as outside of that, even though we uphold all the levels of care? And this relates, questions. How do we negotiate with similar clout? How do we continue to avoid further marginalization of family medicine? And also strategies to improve primary care, to reduce the number of family physicians leaving comprehensive family practice. They're all related, right? In terms of just respect and recognition for the work of family doctors. So maybe Christy, I'll pass it over to you to get started on that first. How do we bring clout to bear? How do we continue to avoid further marginalization and reduce the number of physicians leaving family practice?
So I really just think we need to continue to advocate. I try my best as president, to be at every single table and make sure that the family physician's voice is there. And remind them that in rural communities, 86% of all medical services are provided by family doctors. In remote communities, 100% of services are provided by family doctors. So it's reminding at every table what we do. And then when they talk about, well, let's just build another emergency because our emerges are overrun. There's the one aspect of it that also the majority of emerge docs in this country, the vast majority are actually family docs. And the other piece is you need the upstream, right? So it's far more cost effective to have me being the first point of contact in the community and triaging 9 out of 10, 95 out of 100, that kind of thing, before they even need to go anywhere else or even get a lab test done. I think that's the piece, and as I say, we need to collaborate with our colleagues. I do think that we each have we bring evidence, we bring data, we bring the voice of strictly just the family doctor. That's who we are. And even getting to those, sitting in on those negotiating tables with the medical associations, with each province, and supporting our chapter leaders to actually do that, and those types of things, I think is key.
And I would just add to that excellent point, Christy, that as we sit at those tables, and I'm certainly there to join you in bringing family doctors' voices, the clout comes from our collective. It comes from all of you. And so all of you starting and joining, even just tonight, spending an hour with us to really talk about these. We're going to take these back. We're going to study these questions. We're going to try to figure out how we can continue to tweak our messages, our work, to make sure that it is supporting all of you as members. Really, we are looking at short-term, mid-term, and long-term things that we can do, both to retain immediately the family doctors that we have in the systems now, and making very clear what changes need to be made now to our policymakers, together with our provincial chapters, together with all of our partners, that we're working with in terms of changes to practice, but also making sure that training keeps pace so that we can continue to strengthen the future of our the future practitioners that come out, and also in the longer run, making sure that we continue to demonstrate the important value and really just the long time, lack of attention that has been brought to the important work of family medicine. The reality is that we provide so much more of we provide the vast majority of care. We keep people out of the acute care system, and that needs to be supported, resourced, and recognized. So, with that brings us to the top of the hour. Wherever you are here in our wonderful country known as Canada, from coast to coast to coast, we really thank you for taking the time to be with us this evening. And please, this is the start of a conversation. We look forward to hearing from you and continuing to listening and learning with you in the months to come. Thank you so much.
Thanks.